Good afternoon, wherever you are. We'd like to welcome you to Chest Pulmonary Hypertension associated with ILD, from early detection to management. We'd like to thank Chest as well as United Therapeutics for sponsoring this program. And we're excited to have a great crowd, some really good data, and some really good discussion. So welcome. Next slide. My name is Debbie Levine. I'm from Stanford University, and I'd like to introduce our faculty, Navneet Singh, who is from the Center of Advanced Lung Care at Brown Health University. He's an assistant professor. Sarah Kahn, who is a pulmonary and critical care fellow at Johns Hopkins, and Matthew Hunsucker, who will round out the discussion from the Barrow Pulmonary in Greensboro, North Carolina, and they've all has some very important information to share today. So I think we can get started. Next slide. Next slide. So today we really want to talk about several different topics in terms of PH-ILD. We want to not only kind of talk about the diagnosis and the pathophysiology, but really the need for an early clinical diagnosis and why that's important. Once it's diagnosed, and how to diagnose this is the next thing we'll talk about, and really talk about what are the latest treatment guidelines, what are the emergent therapies, and what are some of the adjunctive therapies and things we should be doing with patients with PH-ILD. And then how can we really improve patient care strategies for everyone diagnosed with pulmonary hypertension and ILD, and how to look for when they're combined. Today, we kind of want to start with a case to bring up all the different areas that we'll be discussing, and so I will be starting with the case. So Sophia is a patient who recently was seen. She's a 54-year-old female. She has a history of ILD. She was admitted through the emergency department just a few weeks ago and was found to have worsening shortness of breath. And I think that's important, that she has ILD, so she already has dyspnea on exertion and kind of moderate shortness of breath. But she felt that she was having an increased amount of shortness of breath, a declining exercise tolerance, not just a bad exercise tolerance, but declining. 2 months ago, she was as, quote, active as she could be on 4 liters of oxygen, doing things around her home and going to the grocery store. But she progressively has increased her own oxygen to 8 liters by nasal cannula. And she hadn't seen her pulmonologist since that time, and just found that she was getting a little bit more fatigued and requiring more oxygen. And I think that's important when you're trying to look at a clinical presentation of someone with PH-ILD, when you're trying to diagnose it on top of someone who already may have the diagnosis of ILD. In terms of how she was feeling, her review of systems, she had no increase in her chronic cough. She's had a chronic cough since she was diagnosed with ILD. In fact, that's how she was diagnosed with ILD. But there was no increase in that. No fevers to make you think that maybe she has a URI or an infection. In fact, she was ruled out for all types of URI by a nasal swab in the ER just a couple weeks ago. She does have some intermittent diarrhea, but that could be from her therapy for her ILD, pirfenidone, which she's had for a while and is really had no change. No other triggers or allergies that can make you think that she had some other exacerbation of her ILD. She did notice some new lower extremity swelling over the last few weeks that hadn't been around prior. She does have diabetes, which is worse with her steroid taper, which she has gotten multiple times throughout the last couple of years. She has a history of hypertension and hypothyroidism, and she's on multiple medications. But the medications that are relevant to us today is she's on a prednisone taper. I think she's on 20 milligrams of prednisone now. She's on pirfenidone, which she's been on for almost 1.5 to 2 years, Synthroid, and amlodipine. And the amlodipine has been on for quite some time, over 2 or 3 years, and she has not had any lower extremity edema from this calcium channel blocker, so that is likely not the case. Next slide. When she's seen in the ER, she's afebrile, she's mildly tachypnic, she has blood pressure that's not too high, but she had progressively increasing oxygen requirements even in the ER over several hours. And now she's only 92% at rest on 15-liter high flow. She's alert. She doesn't describe any difficulty breathing at this point, but she does have an increased JVD, and she has basilar rales, and she's diminished throughout her lungs, no wheezing. Heart rate is normal. She's not an AFib, and she has 1 to 2 plus lower extremity edema, equal on both sides. Next slide. On some studies she had on admission, she has a BNP or an NT-proBNP that's 1,500. That's up from 300 from her visit to her pulmonologist 3 months ago. Chemistry, she's mildly hyponatremic, which sometimes you can see in pH. BUN and creatinine that have up from 1 month prior. She had a prior CKD, and she's got a creatinine that's 2.2 up from 1.67. Mild elevations in her transaminations, AST 44 and ALT 54, and her T-billy is up 1.9 up from 1 month ago. She has a mild anemia, but other than that, her white count is stable, and so is his platelets. Next slide, please. So her CAT scan, she had a PE protocol CT, which many people know is important to get in a patient who has a change in their status for ILD. And what you don't see here is that her CT parenchyma or her lung windows from a year ago were pretty stable, with not really a lot of changes in the parenchymal changes in her ILD. What did change was that she did have an increase, I don't know if you can see my arrow, but an increase in the diameter of her pulmonary artery, and it was enlarged compared to both the aorta, but also to the last CT that she had a year ago. So that was a change as well. Next slide, please. So just as with the CT scan, we did compare her echo. She had an echo done, which showed a small LV cavity, which is comparatively different from the one a year ago. And you can go to the next slide so we can see the differences between the 1023 and 1124 echoes. Her LV was smaller, more hyperdynamic. Her EF is about the same, maybe a little bit less, but her RV had gone from normal size and function to moderate RVE with moderately reduced systolic function with moderate TR, and RVSP, which again is sometimes hard to estimate on a patient with lung disease or chronic lung disease, with 30% of patients having less and 30% of patients having over the estimation. But hers was dramatically increased from 55 to 91, and an RAP, which we also know portends a poorer prognosis, was increased from 4 to 8 with a new trivial pericardial effusion. And I don't know if you can see the bottom, but that's good too. It just said the changes. Next, please. Again, she underwent a right heart cath based on those echoes while she was in the hospital. And again, this was from about a year ago. RA pressure had increased. And even though there are changes on that echo that could be hard to understand with ILD, on the right heart cath, she did have a mean PAP that went from 17 to 32. So she had definitely increased that. Her PA pressure was 10. I'm so sorry. Her wedge pressure was stable at 10 to 12, and you can see that her cardiac index had decreased. Next, to 1.73. These are some serial PFTs. If you can look down at the red boxes, you can see that really in the last few months, when she started getting those symptoms, her FEC has really basically been stable, as has her FEV1, but her DLC had declined somewhat. And if you look down below, her 6-minute walk based in June was 605 feet, and it had gone down dramatically in the last 3 months. Next, please. Oh, thank you. So I think I think we can say that this patient is diagnosed with PH-ILD based on all the studies that our panel will be going through closely. And I think the big thing for the rest of the talk is that really identifying pulmonary hypertension in the context of interstitial lung disease is very challenging. And we're going to go through those diagnostic challenges and how to meet them early and keep a low threshold for looking for them. ILD itself is a progressive disease, and it's unpredictable. Patients get exacerbations for any reason. And so when, number one, patients with PH-ILD have a worsening prognosis than patients with just PH-ILD alone or PH alone. And these unpredictable trajectories and progressiveness of the disease are even worse than just with one of those diseases. So timely recognition is important, and a comprehensive thorough evaluation is important for optimal management. I'd like to turn the slides over to Dr. Singh, who's going to now talk to us about PH-ILD epidemiology and pathobiology. Dr. Singh.
Thank you, Dr. Levine, and thank you to the organizers for the invitation to speak today. So as Dr. Levine said, I'm going to talk about the epidemiology and pathobiology, and I should say first, a lot of what we know about these two topics really only comes from idiopathic pulmonary fibrosis, or IPF. So a lot of what I'll tell you today comes from that world of the literature. We do know a little bit more about some of the other subtypes, but please keep in mind the data are limited. Next slide. So when we talk about ILD in general, most commonly we're talking about fibrotic lung diseases that are complicated by pulmonary hypertension. Typically, inflammatory lung diseases are less likely to be complicated by PH. And as I said, prevalence data are limited. We think somewhere between 8 and 15% of patients with IPF at the time of their initial workup will have a mean PA pressure equal to or greater than 25 millimeters of mercury. The prevalence is, again, less known in other subtypes of ILD. These are two single site reports. In NSIP, one report of 31%, and in chronic HP, 44%. So you can see it varies quite widely. Next slide. When it comes to fibrotic lung disease, the type of PH that people end up with, people with fibrotic ILD often have mostly mild to moderate pH, somewhere with a mean PA pressure between 21 and 34 millimeters of mercury. This information comes from a large cohort of patients with IPF who are listed for lung transplant. And in this cohort, about 20% were found to have mild pH, 30% with moderate, and 10% with severe, which was defined as a mean PA pressure greater than 35. Interesting, 40% of these patients at rest had no pulmonary hypertension. Next slide. So what are some of the poor prognostic factors as we're working these patients up? And so some of these things we saw in Dr. Levine's case. Obviously, it's probably intuitive. A higher mean PA pressure would be a more poor prognostic factor. PVR greater than 5 Wood units is thought to be a poor prognostic factor, although it's thought that maybe 8 may be a better threshold to discriminate survival best. But those data really are somewhat unclear. A cardiac index less than 2.5, which Dr. Levine's patient did have, is another poor prognostic factor. On PFTs, a DLCO less than 35% is another marker. Echo can be helpful because obviously we're not cathing these patients as often and sometimes following them with echo. And so certain signs that we can see that might portend to poor prognosis include an estimated systolic PA pressure greater than 45, a right ventricular fractional area change, or FAC, less than 28%. And then you can calculate, or sometimes is reported, the ratio of the TAPC over the systolic PA pressure less than 0.26. Not all of our patients have cardiac MRIs, but if they were to have one for whatever reason, RV strain obviously is similarly or poorly prognostic. Next slide. When it comes to connective tissue disease ILD, one thing to note, of course, is that the phenotypes really vary widely, which should be unsurprising. And maybe because of this, the data are even more limited than an IPF. And so there's a lot on this slide, but sort of breaking down different types of disease, I use systemic sclerosis as an example. Because we know that systemic sclerosis, mixed connective tissue disease, and RA are commonly complicated by ILD. In systemic sclerosis ILD-PH, the prevalence still is poorly characterized, somewhere between 6.1% and 31.2%. But the survival data is even more discrepant. So in one 2013 meta-analysis, the report was that for systemic sclerosis patients with PH, the survival was 56%. And in those patients who had PH and ILD, the survival was much lower at 35%. But in a separate study, in a registry of Spanish patients, it seemed that the survival was not much different, whether the patients had ILD or not. And so whether the ILD really portends a worse prognosis in the systemic sclerosis population with PH is still somewhat unclear. The other types of connective tissue disease that can lead to PH, including mixed connective tissue disease, have even less data because these are inflammatory diseases that sometimes behave differently and may respond to therapy differently than fibrotic lung diseases, and so that remains unclear to us. Next slide. CPFE, or combined pulmonary fibrosis and emphysema, is a phenotype that has become more important to us over the last several years. And the reason is that we know now that PH occurs in somewhere between 30 and 50% of patients with CPFE. And when it does occur, it tends to be more severe with a worse prognosis when compared to people who had either fibrosis or emphysema alone. And so this combination in these patients seems to be develop a much more severe phenotype. And this happens clinically too. We note that these patients are more symptomatic, have a higher oxygen requirement, and on CPET are markedly more impaired. Next slide. So now going back to IPF for a few minutes, talking about IPF in general, we know that it is the most common type of ILD. It's about 20% of all cases of ILD and tends to happen more in men than women and increased risk in those who smoke. And even small elevations in echocardiographic mean PA pressures, more than 17 millimeters of mercury, which we wouldn't normally consider suggestive of PH, are associated with reduced survival in IPF. And interestingly, the degree of parenchymal involvement does not correlate with the PH severity, suggesting that there's something going on beyond just the fibrosis itself. Next slide. And this really matters, right? And so the effects on survival really are there regardless of the severity of the PH. And so you can see on the right-hand side here, this is a survival curve. And the top curve in blue are people who have no PH. And then the rest of the curves are divided people who had borderline PH, mild or severe PH. And you can see that even the people who had mild PH had a significantly decreased survival compared to those who had no PH. Next slide. And so let's move on to talk a little bit about pathobiology. On the left-hand side here, you can see a normal lung with the small airways depicted and the interstitium below that. On the right-hand side, you can see a lung with idiopathic pulmonary fibrosis, and you can see that the bronchi are dilated and there is a significant amount of interstitial fibrosis and alveolar remodeling. And so you can see in the interstitium below all the scarred interstitium that's interfering with gas exchange. Next slide. And we see this on CAT scan, of course, and here's an example of that correlate, the usual interstitial pneumonia that's remarkable on CAT scan that we see sometimes in people with IPF. Next slide. Now, where does this come from? Our thoughts about IPF pathogenesis have changed over time. We used to think that it happened because of chronic inflammation that was leading to injury and then fibrosis. Next. And we now know that it really has a lot to do with abnormal wound healing. We think that there are repeated stimuli causing repeated injury, and it's the abnormal wound healing that's leading to the fibrosis. Next slide. Next. So let's drill down briefly into that a little bit more. So we know that these epithelia undergo aberrant repair, and this causes the fibroblasts to aggregate into activated myofibroblasts. These epithelia that line the airways transform into mesenchymal cells and then respond irregularly to injury. And we also know that there's a genetic predisposition. Many of us are aware of the MUC5B gene mutation. Next slide. What are some of the physiologic mechanisms that link IPF and PH? Well, hypoxic vasoconstriction is one we think about a lot that causes vascular remodeling. We also know that due to alveolar destruction, there's small vessel phallus, particularly in the periphery of the lungs. We also are aware of constrictive fibrosis as interfering with gas exchange and respiratory physiology. And then we sometimes postulate about pulmonary venule involvement. And this is an area that we oftentimes don't get a good diagnosis about, but we see oftentimes on autopsy after death. Next slide. Here's what that looks like under a microscope. And so you can see on the left-hand side, a pulmonary artery that's branching out from an area of fibrosis, all that brown, red-looking area, into the area of normal-looking lung that's more open. On the right-hand side, you see stained in pink smooth muscle cells that have caused hyperplasia in the interstitium of the wall of a pulmonary artery. Next slide. And finally, I'll leave with just a note about the genetic predisposition. We know that the genetic signature in IPF is actually consistent either with or without PH, and that's very interesting. It suggests that this genetic reprogramming is happening before the development of PH. And so there's some additional mechanisms or hit that are predisposing patients to the development of PH in IPF that is apart from the genetic signature itself. And with that, I'm going to turn it over to my colleague, Dr. Khan.
Thanks, Dr. Singh, and thanks to the organizers of this webinar for inviting me to speak today. I'm going to be talking about strategies for screening patients with pulmonary hypertension or with ILD for pulmonary hypertension. And this is a topic that's difficult to discuss without acknowledging the fact that there are currently no evidence-based guidelines to inform us about how we should do this. Next slide. And the lack of guidelines is really reflected in the current practice patterns that we see across the United States. So we conducted a survey with the Pulmonary Fibrosis Foundation and the Pulmonary Hypertension Association of ILD and PH specialists across the U.S. at specialty care centers and asked them how they approach screening their ILD patients for PH. And when we asked which patients they screened for PH, 53% said that they screen all of their patients, 44% said that they screened some of their patients, and 3% said that they weren't sure that how they approach screening their patients. Next. And so when we asked further, for those who said that they screened some of their patients, we found that clinicians are using a combination of clinical signs and symptoms, which are suggestive of the development of PH, along with physiologic data and knowledge of their patients' underlying diseases and comorbidities to determine who needs to be screened for pulmonary hypertension. Next. Delving a little bit more into what those signs and symptoms are, a number of clinicians said that they look at worsening symptoms of exertional dyspnea or functional limitation. And these can be difficult to assess because they can be signs of worsening ILD itself, or they may be indicators of developing pulmonary hypertension. Other signs and symptoms that were cited as the prompts for screening for PH included symptoms of chest pain or pressure, unintentional weight gain, peripheral edema, syncope or pre-syncope, cardiac arrhythmias, sensations of palpitations, and physical exam findings such as a loud P2 or S2. And I also think it's important to point out here that a number of these signs and symptoms are indications of right heart failure, which develops fairly late into the disease course of PH, so after PH has already developed. Next. In terms of physiologic data, clinicians cite using pulmonary function tests, 6-minute walk tests, and chest imaging to assess their patients for developing pulmonary hypertension. When looking at PFTs, we're looking primarily at the DLCO or diffusing capacity of the lung for carbon monoxide. Suggested cutoffs for DLCO indications of PH include levels less than 40% predicted or declines of at least 15% from patient's baseline. This should be FVC to DLCO ratios, which are increased. So ratios which indicate that there is diffusion limitation out of proportion to restricted lung disease. This number of 1.6 has been suggested as a cutoff to use as a potential indicator of PH, but this was developed and has been investigated primarily in patients with scleroderma ILD and PH. And so the exact number to use and how it should be applied to patients with other forms of ILD is a little less clear at this time. In terms of 6-minute walk tests, we're looking primarily at how patients' distance walked has changed over time and the severity of desaturation. There's also some evidence that abnormal heart rate recovery after 6-minute walk testing is also indicative of pulmonary hypertension. And then finally, when we're looking at patients' chest CTs, we can measure the diameter of the pulmonary artery and compare it to the diameter of the aorta. Ratios of 0.9 or higher are typically seen as indicative of pulmonary hypertension. Next. And the last piece of clinical data that we frequently think about in terms of thinking about which of our patients are at increased risk for pulmonary hypertension are the patient's underlying diseases and comorbidities. So patients with connective tissue disease-related ILD may have an increased risk for PH related to their underlying connective tissue disease itself, and this is especially true for patients with scleroderma. Patients with sarcoidosis or combined pulmonary fibrosis and emphysema, as Dr. Singh pointed out, are also at an increased risk for PH. And then there are other comorbidities, including other organ dysfunction, including left heart disease, especially heart failure with preserved ejection fraction, renal failure, and chronic liver disease, all of which increase patients' risk for pulmonary hypertension. Patients with a history of VTE have an increased risk for PH, and then exposure to specific medications or substances, particularly such as amphetamines, can also increase the risk for PH. Next. So we have a few tools and things that clinicians are looking for as they're taking their histories and examining their patients that may indicate which patients are at increased risk for PH and may need to be screened. But there's even less consensus about how frequently we should screen our patients. So in our survey of ILD specialists, 21% said that they screen ILD patients for PH when they initially present to them. 36% said that they screen patients if they have a change in their clinical status, and 43% said that they screen their patients at regular intervals. Next. For those who screen their patients at regular intervals, 43% said that they screen their patients every 3 to 5 months. 46% said that they screen their patients every 12 months or more. And then a few said that they screen every 6 months. Next. And in terms of the tests that are used to screen patients for PH, this table now reflects ILD specialists who responded to our survey, along with PH specialists who were part of the Pulmonary Hypertension Association. And across both specialist groups, the majority are using echocardiography as their primary screening tool for PH. A third say that they also check pro-BNP levels as indicators of possible PH. A smaller number of respondents said that they use 6-minute walk tests. And then a few respondents from the Pulmonary Hypertension Association also said that they use cardiopulmonary exercise tests to screen their patients for PH. In this survey, we included right heart caths as a screening test, but I've graded out here because it's really not a screening test, and it's an invasive test, and it's really the gold standard tool that we use to diagnose pulmonary hypertension, and I'll touch on that shortly. Next. You can click through these. Thank you. So a number of studies have investigated whether we can use the signs and symptoms, the clinical testing that we do, and our knowledge of our patients' underlying conditions to develop risk scores for pulmonary hypertension that we can apply to patients each time they present to us and make an assessment at each point in time to say, well, is this patient more or less likely to have PH at this time? And if they are, that may be an indication that the patient needs to undergo further diagnostic testing. Next slide, please. Thank you. And so this is a comparison of several risk scores that have been published since 2008. All of these use the DLCO in some capacity, either as the percent predicted or as the ratio in comparison with FVC. Some of these include measures of oxygenation, chest imaging measurements, echocardiogram, and patient demographics. But really across the board, these perform quite similarly in terms of their sensitivities and specificities, indicating that they all do a fairly good job of detecting PH in patients who have PH, but none of these is really better than another. In fact, Dr. Steve Nathan's group published earlier this week a direct comparison of several of these tools. So the study the risk scores published by Zitzman et al., Parikh et al., and then his own group's Ford Index and Ford Calculator. And they all had C statistics, so measures of how well these risk tools can detect PH. All had C statistics around 0.7, indicating that, they all perform similarly, and they perform well, but none of them stands out from another. Next. So I think the main thing to take away from all of these tools and signs and symptoms and all of the potential evidence that we may find of pH in our patients is that we have a lot of information as to what might suggest that patients have pH, but we don't really know how to put it all together at this time. And so we really need evidence-based guidelines. And to develop evidence-based guidelines, we need good evidence. And this is a difficult topic to study. Next. And I do think that it's important to screen all of our patients with ILD for pH. Again, I think this is a place where we need guidance, but this is one proposal that came out of a Delphi consensus study in 2022, which incorporates all of the signs and symptoms and physiologic testing that we've discussed, and essentially asks, do we have any suspicion that patients have pH? And the recommendation is that if we have no suspicion, we don't need to do any further workup. But if we have any suspicion that our patient with ILD has pH, then we should proceed with echocardiography. Next. There's still, I think, even less data or evidence to suggest how frequently we should be screening these patients. And I think all I can tell you at this point is that everybody's going to have a different answer. At our institution, we screen our patients annually with an echocardiogram, but at the same time, we should be assessing for all of these signs and symptoms at every time we see our patients. And anytime there is a clinical change, we should also be assessing our patients for pH. Next. I think the most important thing is that if we have any concern that our patient is developing pH or has developed pH, we need to refer these patients early to a pH specialist for the evaluation and to determine if they need further diagnostic testing. Next. So I'm going to speak briefly now on just how we actually diagnose pH in these patients. Next slide. So right heart cath is the gold standard for diagnosing pH. It's the means by which we directly measure the pressures in the pulmonary artery. And so this is a procedure in which we access the central veins, typically through the internal jugular, pass a catheter through each of the heart chambers, the right atrium, into the right ventricle, and then into the pulmonary artery, where we take direct measures of the pressures and then indirectly measure the pressures on the left side of the heart as well. Next. And this just illustrates as we're passing through each of those chambers of the heart, we are taking these measurements, and we're comparing in each patient their own measurements with what is considered normal. Or next. I think that it's important to note that the definition of pH has evolved over time and continues to evolve. This is the most current iteration of our definition of pulmonary hypertension. This was most recently updated in 2022 by the European Society for Cardiology and European Respiratory Society, and was endorsed by the World Symposium on Public Health meeting. And the first assessment is just looking at the mean pulmonary artery pressure. If it's greater than 20 millimeters of mercury, then the patient has pulmonary hypertension. But we then have to assess from there whether they have primarily pre-capillary, post-capillary, or combined pre- and post-capillary pulmonary hypertension. And this involves, again, using our indirect measures of the pressures on the left side of the heart, our assessment of the resistance across the pulmonary vasculature. This has important implications for thinking about treatment options for our patients. Next. And the second aspect of diagnosing patients with pH is making sure that we understand all of the contributing factors for their pH. So again, this has important treatment implications that Dr. Hunsucker will touch on. But the World Symposium on pH has defined 5 groups of pulmonary hypertension, which each reflect a different underlying cause of pulmonary hypertension. And so what we've been talking about today has been pH related to chronic lung disease or hypoxia, so group 3 pulmonary hypertension. But as we're assessing our patients, even before they go to right heart catheterization, we need to be thinking about what are the other potential contributors to pH for each individual patient. As patients get echocardiograms, as we do their right heart cath, we're looking for evidence of left heart disease, if and it's important to rule that out. Next. We also perform ventilation perfusion scans and can perform angiography at the time of right heart catheterization to evaluate for evidence of thromboembolic disease. Next. And as we take our histories and evaluate our patients with labs and other workup, we're also looking for other systemic conditions which could contribute to pulmonary hypertension. These include hematologic disorders, disorders like sarcoidosis, or other diseases that can affect the lungs, but also have other or systemic chronic renal disease and other organ dysfunction. Next. And so after ruling those other causes of PH out in our patients with interstitial lung disease and precapillary pulmonary hypertension, we can fairly confidently say that they have group 3 pulmonary hypertension or pulmonary hypertension caused by their interstitial lung disease. Next. And so I will now turn it over to Dr. Hunsucker, who will be talking about the treatment of pulmonary hypertension in our patients with ILD.
Thanks, Dr. Khan. And thanks everyone for joining us today. It's really important work, and I'm excited you all are interested in increasing the awareness of this entity of PH-ILD. I've been tasked with going over the treatment, and so we'll jump right in if you'll go to the next slide, please. So I briefly, as an outline and part of my talk, want to hit on these topics primarily, and we'll jump through them as we go. But I think it's really important to understand the pharmacologic pathways for treatment of pulmonary arterial hypertension, or PAH, and really impress upon you that PH-ILD is a unique entity within pulmonary hypertension. And hopefully, as we go through some of the clinical trials, that theme will be impressed upon you, particularly in these pulmonary arterial vasodilators and pulmonary hypertension-associated ILD. We'll touch on the current pharmacologic treatment of PH-ILD, which is, frankly, in its infancy or toddlerhood compared to pulmonary hypertension or PAH and other diseases. And I really want to talk about adjunctive therapies for PH-ILD, as these remain the backbone of treatment for our patients. Next slide. I think a theme I heard through my colleagues, and I hope you've heard too, is that managing PH-ILD can be quite challenging. We have two disease processes that are that progress or worsen over time in the vast majority of our patients. And often it's difficult to ascertain, which disease process is driving this clinical worsening. And so I find that diagnostic tests or other tests are helpful in differentiating between the two and help with treatment decisions. And certainly with exacerbations or worsening, but I often find that following some of these testing modalities over time and developing a trend is most helpful, as often there can be test-to-test variation, but trends over time often will show you the path that the patient is going down. So in particular, echocardiogram, and while RVSP and PSP, or right ventricular systolic pressure, and pulmonary arterial systolic pressure are important, I find that looking for structural changes, right atrial dilatation, improvement or worsening, right ventricular dilatation, improvement or worsening, and function of the right ventricle, improvement and worsening over time with treatment are important. Trending to BNP, or B-type natriuretic peptide, over time. And while I don't routinely get right heart catheterizations in serial tests, it certainly is an important tool to help differentiate when we really can't tell despite non-invasive testing. I find pulmonary function tests to be particularly helpful, looking at changes in FVC or total lung capacity. But as has been pointed out, often the DLCO, or a decrease in DLCO out of proportion to those capacities or lung volumes, can be really telling to the development of pulmonary hypertension. And then lastly, looking at high resolution CT scan of the chest and comparing to prior images to look for signs of worsening parenchymal changes, worsening areas of fibrosis, or increased areas of fibrosis. And while the physical exam is certainly very helpful and the history is certainly very helpful, I find that sometimes we miss things or fail to ask the right questions. And so using these testing modalities are quite helpful. And I think, referral to a pulmonary hypertension center or a pulmonary hypertension expert is really important in caring for these patients. Certainly the expertise in treatment and side effects and helping manage and walk through that with patients, but also expertise and consideration of clinical trials and familiarity with lung transplant is really important. Next slide, please. So speaking of adjunctive therapies for PH-ILD, again, I think these really remain the backbone of helping our patients and treating our patients. And certainly, recognizing when hypoxemia develops and providing timely and efficient oxygen therapy has been touched on by many of my colleagues. The hypoxemia or oxidative stress leads to pulmonary arterial vasoconstriction, which certainly can lead to acute, but also chronic worsening of the right ventricular function over time. Diuretics remain important as volume overload develops in all forms of PH, and PH-ILD is no different. I think maintaining or increasing level of activity is certainly paramount to helping people both primarily with their quality of life, and certainly pulmonary rehabilitation is really important. Engaging in those programs in your community, certainly the expertise that our colleagues bring through those programs, but also the social aspect and the social support network that can be developed with patients going through similar symptoms is really important. The investigation and treatment of obstructive sleep apnea is key, as there's a large concomitant component of that in our population, but certainly can contribute to worsening pulmonary hypertension or right ventricular changes over time. And I think just given the epidemiologic importance of WHO group 2 pulmonary hypertension or pulmonary hypertension related to left-sided structural disease, it's really important, especially as we're evaluating serial echocardiograms, to identify that and seek assistance from our colleagues to help treat that as effectively as possible. Next slide, please. So this is a cartoon just going through 3 pathways that we currently have for pulmonary arterial vasodilators. And really the goal of each of these pathways is to promote vasodilation and prevent proliferation of smooth muscle cells. Dr. Singh presented a great histopathology of that and seeing those changes and trying to prevent that chronic remodeling that reaches an end stage that our therapies don't work anymore. And ultimately, we want to result in decreased pulmonary vascular resistance, a decreased pulmonary artery pressure, and preserving that right ventricular function as long as we can. And so the 3 main pathways include the endothelin pathway, the nitric oxide pathway, and the prostacyclin pathway. And there are multiple pharmacologic agents in some of these different pathways. Next slide, please. So as we go through these clinical trials, again, I want to impress upon you that PH-ILD, while it is pulmonary hypertension, is unique in the world of pulmonary hypertension. And, going through this table here, these are 6 trials with endothelin receptor antagonists, again, approved and used to treat PAH, including bosentan, macitentan, and ambrisentan. And you can see over the course of nearly a decade, multiple studies were conducted, and none of them met the primary outcome that was conceived at the time of the trial. We can go to the next slide. Similarly, phosphodiesterase type 5 inhibitors, which block the degradation of cyclic GMP and lead to vasodilation and decreased smooth muscle proliferation. Again, 3 different trials over the course of a decade, all with sildenafil, that again did not meet their outcomes despite showing benefit previously in PAH. Next slide. And lastly, soluble guanylate cyclase stimulators. Again, this is in the pathway that increases production of cyclic GMP, vasodilation, and decreased smooth muscle proliferation via riociguat. This trial in 2019, again, did not meet the preconceived or the outcomes of the trial. Next slide. So why might this be? And I think in some ways this may be oversimplified, but I think it's a really key concept to understand, in that in the setting of parenchymal lung disease, the body has a natural compensatory mechanism to divert blood flow away from disease where gas exchange is hindered or limited. And this maximizes ventilation and perfusion matching within the parenchymal lung disease, in that you get a smaller fraction of deoxygenated blood mixing back with oxygenated blood in the pulmonary vein, going to the left side of the heart and going to the rest of the body, therefore decreasing the chance or decreasing the degree of hypoxemia. With systemic pulmonary arterial vasodilators, that disrupts this mechanism as indiscriminate or systemic pulmonary arterial dilatation, and can often lead to an increased fraction of deoxygenated blood mixing with oxygenated blood, leading to decreased oxygen saturation. This is a phenomenon that I describe as shunt, and often leads to worsened hypoxemia and dyspnea. So really, there's probably more complicated and more to it, but I think it's a key concept to understand as we try to understand why these drugs did not help in PH-ILD in the past. Next slide. So there is a trial published in 2020 of an inhaled pulmonary arterial vasodilators, and this was inhaled nitric oxide. Again, this increases cyclic GMP, as we mentioned before. Well-designed trial, double-blind, placebo-controlled. And these subjects were at risk for PH-ILD. So based on echocardiogram, some did have diagnosis of PH via right heart catheterization. So that's one limitation of the study, is not everyone had PH as is defined by the gold standard. And they received pulse nitric oxide via nasal cannula at escalating doses. And it did show an improvement in their designed outcome, which was basically increase in moderate vigorous activity, or the questionnaire. So this gives some hope that maybe inhaled drugs would be a potential pathway to treating our patients with PH-ILD. Next slide. So why would these be more effective? Well, theoretically, the medications would only be effective where there's adequate perfusion of ventilating matching, meaning the uptake of drugs in areas with adequate perfusion. So the drug would not be taken up in areas of fibrosis. So you would get preferential pulmonary arterial vasodilation at the areas of perfusion and ventilation matching, which would not cause shunt or worsening ventilation perfusion mismatch. So hopefully, again, decreasing systemic pulmonary vascular resistance and PA pressures without the shunt or worsening hypoxemia. Next slide. And in fact, there's an inhaled pulmonary vasodilator approved in PAH via the Triumph trial in 2010. Again, a well-designed trial via the prostacyclin therapy, or prostacyclin pathway, and this leads to vasodilation and decreased smooth muscle proliferation. They were either on background therapy of bosentan or sildenafil, and this did meet the primary outcome of improvement in 6-minute walk distance at the designated point in the trial. Next slide. So this brings us to the landmark trial, the INCREASE trial in 2021, which gives us what led to FDA approval of inhaled treprostinil for pulmonary hypertension and ILD. Again, a well-designed, multi-center, randomized, double-blind, placebo-controlled trial of inhaled treprostinil monotherapy. Participants were at least 18 years old with ILD on CT scan and diagnosed at the time with Group 3 PH prior to the updated ERS and symposium recommendations or guidelines. These patients were diagnosed on right heart catheterization with a mean PA pressure of greater than 25, a wedge of less than 15, and a PVR greater than 3. And the primary outcome was achieved, increase in 6-minute walk distance. Next slide. So here is a graph showing that at 16 weeks with the inhaled treprostinil, an increase in 6-minute walk distance of about 21 meters. I also wanted to point out in the gray, the placebo, that there is a trend, if not a statistically significant decline in 6-minute walk distance. Just another reminder that this is a progressive disease and leads to clinical worsening, sometimes quite quickly. And early recognition and treatment is really important to try to stymie this. Next slide. So some of the challenges of inhaled treprostinil from the manufacturer's website, this is where it's taken from, but I think that, the frequency of dosing can be challenging. It's 4 times a day, initially in a nebulized formulation with multiple breaths many times a day, a lot of room for error or mistake there. And then there is a dry powder inhaler device available that's theoretically 1 inhalation 4 times a day, but those doses can be increased to where the inhalations could be multiple. The side effects include cough. In my clinical practice, I find this to be the biggest issue. Work really hard to mitigate this and develop strategies to prevent this. But as a class effect with prostacyclin therapy, things like low blood pressure, platelet dysfunction, headache, nausea, diarrhea, and syncope can occur and are most frequent per the manufacturer. Next slide. And so I'll throw it back to Dr. Levine and finish the case.
Thank you, Dr. Hunsucker. We can go back to Sophia. I think if we can go to the case. So one thing, there was a great question during the talk about Sophia and if she underwent a VQ scan, which was an excellent question. In the ER, she did not, but during her hospitalization, she did get a full workup. Besides the PE protocol CT that she had, she also got Dopplers and a VQ scan looking for chronic thromboembolic PH, which I think is important when you're thinking about a patient who has ILD or any other chronic lung disease who's worsened significantly. And a PE protocol CT oftentimes will not help with that, but looking for chronic thromboembolic PH VQ scan would be great. And she did have that. She had the reason she had that is because she worsened over the next several days in the hospital, such to the point that she had to come to the ICU, and because of increasing oxygen requirement and even in hemodynamic instability that progressed over time. At that time, she was placed on pressors. She needed to be on inhaled nitric oxide. And this is a patient that when she was just admitted, we had considered an inhaled prostacyclin, but she progressed very, very quickly and needed to go to the ER. She did not, to the ICU. Discussions on whether she would require ECMO during this time. She stabilized somewhat with pressors and inhaled nitric, so she did not end up going to ECMO at that time, but she did undergo a thorough and complete urgent inpatient evaluation for lung transplantation. And luckily, she was able to handle all of those testings and be able to be listed for bilateral lung transplant. And she remained in the hospital because of her high oxygen requirement and her pressor requirements, and waited for suitable organs, which, because of her state or her high CAS score, she was able to get transplanted within weeks after transplant, after listing. Again, stayed in the hospital during that time. She's now recovering post-operatively inpatient. But again, one of the things that we will talk about is when patients do have progressive PH or any amount of PH with their ILD when they go into lung transplant, they do have a more challenging time perioperatively, hemodynamically, post-operatively, even after a transplant. So it is important to consider these patients, and we can go to the next slide. I think the big thing here, and I think what everyone in all of their fantastic talks have really pointed out, that just ILD itself, with or without PH, is an unpredictable disease state. And when you add the next slide, if you can go to the next slide, is that even on therapy, PAH or ILD or PH-ILD are progressive diseases. And this is an old study by Steve Nathan, but I've always liked it because even when you're considering a patient for a lung transplant, or even at the end stage of their disease, they're on all the therapies you can put them on, and you've even listed them for lung transplant. This is a nice study that looked at a patient who had a pre-transplant, their pre-transplant evaluation right heart cath, and then their right heart cath or their SWAN that was put in during the time of transplant. And you can see that almost every single one of those patients had a progression of their mean PAP in that time, whether it be, who knows how long each patient was during this time, but it is a progressive disease. And so treating these patients, following these patients is important, but there are not really any definitive therapies at this time, except possibly, next slide, please, lung transplantation. So when you talk about PH-ILD, I thought this was interesting, looking at both the International Society of Heart-Lung Transplant guidelines from 2021 of when should you be referring patients for actually listing patients for lung transplantation. Well, if a patient has that box is in the wrong box. I'm not sure why it's there, but really one of them is when there's any type of pH that's seen. It should be, the red box should be on the pH one, but the hospitalization is good too. But when a patient has pH on the right heart cath, or if it's shown of 2D echo in the absence of any diastolic dysfunction, and you look at the pH, just like I think Dr. Khan talked about, is we also have to rule out all the different types of pH that can occur in an ILD patient. Remember, these patients are usually in their 50s or 60s, maybe 70s, and they have already other comorbidities, including, diastolic dysfunction, heart failure, diabetes with maybe some HFpEF. I mean, these patients can have CTEPH, as our attendee who put that question in the chat discussed. So really knowing the patient has PAH or precapillary pulmonary hypertension or right heart cath, these are times to may have an earlier referral to lung transplant. And then when you look at the pH guidelines from the WSPH, Dr. Saval wrote, when should you be looking at an earlier diagnosis of PH is when they do have underlying lung disease, and ILD and CPFE are in there. And those patients with severe RV dysfunction, they have a difficult time than patients with just either ILD or PH itself. And I think one thing that we do want to recognize is that patients with ILD or combined CPFE are the patients who do have oftentimes the worst prognoses. So next slide, please. So when you're talking about a discussion or referral considerations, and this is not listing or doing a transplant, but for select patients, lung transplant may be the most viable option, but you want to make it available to them. So early discussion with your PH-ILD patient is important because of some of the limitations and unpredictability of the disease and the progressive nature. Some of the reversible obstacles that can occur in patients who have other disease states, maybe they're obese, maybe they have something that's addressable, excuse me, that can be improved with enough time before transplant. Luckily, Sophia was able to get listed and transplanted pretty quickly. And some patients have, excuse me, things that they need done prior to that. Again, projected time and waiting for an organ depends on many allocation, center, and patient-related factors, even after listing. Next slide, please. Sometimes our therapies are not enough, and sometimes patients are not transplant candidates for one reason or another. And in that case, really understanding where palliative care fits into this whole spectrum of therapy. And oftentimes palliative care is not just hospice, and it talks about assessment and management of symptoms that may not be relieved with our therapies, oxygen, pulmonary rehab, and really can help, not only help for support for the patient, both physically, mentally, and spiritually, but also their caregivers. So this is an important therapy for us not to forget and keep in our armamentarium. Under the umbrella of palliative care is hospice services, and at that time, reassessing the symptoms, treatment options, and goals of care is important, and really can be very important for patients at this point. So I think these are all good things in terms of how we looked at Sophia after her really rapid decline over time. And so thank you so much. I want to turn it back to Dr. Hunsucker to talk about summary. And then remember, we do have the ability to answer questions in the chat. So go ahead, or in question and answer, and we can do that after. Thank you.
Thank you. We'll move to the next slide. So I think just in summary and recommendations to leave with you all is that, PH-ILD is overlooked and underdiagnosed. I think Dr. Singh did a great job of going through the epidemiology as we understand it, but certainly there's a lot of limitations in the data there and a lot of work to be done, as Dr. Khan pointed out, in developing tools for screening, et cetera. Early recognition and diagnosis is critical to improve clinical outcomes. This was shared throughout the talk today. Right heart catheterization and hemodynamics are necessary for the diagnosis, while echocardiogram is important for screening and maybe assessing ongoing changes. Really, right heart catheterization remains the gold standard and needed to make sure that we can provide the appropriate treatment based on the hemodynamics we are seeing. The physiology of PH-ILD is unique, presents challenges in both the diagnosis and the management. And treatment consists of pharmacologic therapies, and truly relying on the adjunctive therapies, and at times palliative therapies remains certainly crucial to caring for our patients. PH-ILD should be managed by a pulmonary hypertension center or expert to help provide expert care and in both pharmacological care, adjunctive therapies, consideration of clinical trials, and familiarity with lung transplant. As lung transplant remains the only curative or definitive therapy, and early referral is crucial, as Dr. Levine spoke to. And certainly, I hope to impress upon you that more work is needed, that we can better understand and treat PH-ILD and help care for our communities in the future. Next slide. And lastly, just some acknowledgements. First, I want to thank the staff at CHEST for their outstanding support and organization and their commitment to making this a successful webinar. So specifically Beth Corey, Anna Mustafa, and Sharon Smith, and I'm sure there are others I forgot, but truly thank you for your help and support. I'd like to thank United Therapeutics for sponsoring this webinar and helping bring more awareness to PH-ILD, that work that's so important to all of us. And lastly, we'd like to thank my panelists, Dr. Khan, Dr. Levine, and Dr. Singh, for their commitment to PH-ILD, for their commitment to this webinar. Their passion for caring for their patients is certainly infectious and a huge encouragement to me. So thank you all. With that, I think we have time for questions and answers.
Looking at Dr. Zabari's question, how long can we continue inhaled treprostinil? Is there any data? I would give that to Matt or Sarah, if you have any idea.
Yeah, I'm happy to jump in. I mean, I think the reality is we're pretty limited in pharmacologic therapy. And so my goal is to keep people on inhaled treprostinil for as long as possible. And so I have patients, certainly on it for years. And, does the efficacy wax or wane over time? I think certainly that there needs to be work to look into that. Sometimes we do dose escalations above and beyond what was studied in the increased trial. So to answer your question, I kind of keep it on the indefinitely. And if there's any sign of worsening, certainly escalating those doses are often a time for me to pause and think about, lung transplant referral.
Any other questions for that?
I'll add regarding the sildenafil. So, while you're right that the data for the primary outcomes for those trials were not met, there are data that sildenafil and IPF, specifically the subgroup analysis in those studies, that it may improve RV function and maybe clinical outcomes. And so, while it may not be a primary indication in those patients with for sildenafil, it seems to be somewhat safe and may have some benefits that we are just not coming up to the top. So that's why you may see it used in these patients.
Yeah, and I totally agree. And often, sometimes we'll challenge my patients. I try first line therapy with inhaled treprostinil, and there are actually some guidelines to suggest with certain elevations of PVR that certainly could be beneficial. I think it's really important that we monitor for side effects or adverse reactions, and also acknowledging that the United States is fortunate to have inhaled treprostinil, where other portions of the world is not approved, and so it remains a really important therapy for PH-ILD in other areas. Thank you.
We probably can go through one more question. We are over time, but I thought this was a very good question for those of us who are not able to always get a right heart cath. And this is from an anonymous question attendee, but in view of the prevalence of disease, I'm so sorry. I'm so sorry. It's really talking about, the question was, what happens if we do not have right heart cath available to us and we only have the echo? How would we consider doing that treatment? And this is not uncommon, especially in other countries. And so would love to hear from the panelists on that as well. It's a difficult question, I know, probably not one to take up in 1 minute. But
I'll just add that, there are studies that look at the use of echocardiography alone to diagnose PH in resource-limited countries. We see a lot of them just to psoriasis PH because of how prevalent it is, especially outside the Western world. And so it's not completely unreasonable, and it has been studied. It's just difficult because in this particular disease space, we don't really have a lot of data to support it for ILD PH specifically. So, but I don't think it's unreasonable, and just has to be interpreted carefully. And as Dr. Khan mentioned in her answer in the Q&A, thinking about the entire picture of the echo, but also the clinical context of the other things going on, the other diagnostics that are available to the physical exam. I think it wouldn't be unreasonable, but probably deserves more study as well.
Thank you so much. Thank you, everyone, for coming. I want to thank everyone for coming this afternoon and our wonderful panel, and Chest and United Therapeutics for sponsoring this, and looking forward to more to come. And again, thank you.